Hi everyone, my name's Danielle Breen and I'm one of the embryologists at TFP Fertility. This video today hopefully will be just to give you some more information in addition to the patient guides you should have already been given by the clinic, and just to bring to life a little bit more about biopsy and what you need to consider in advance. So what is PGT? PGT stands for Preimplantation Genetic Testing, and there's 3 different initials that follow after those to decide the different types of biopsy and specifically what we're looking for. So PGT is what we're doing, biopsy is the procedure of removing cells from the embryo. Now, with PGT, the first to discuss is PGT-A. Now, A stands for aneuploidy. That's just a scientific word for the number and the total number of chromosomes. So with PGT-A, we're looking at how many chromosomes are in the embryo. And the premise of this should be that half come from the sperm and half come from the egg, and 2 halves should make a whole. However, that's not always the case. And if we have even just 1 extra or 1 missing, 1 less chromosome, that's normally lethal to the embryo, and that embryo would not be able to implant or would unfortunately result in a miscarriage. The next type of biopsy is PGT-SR. Now, in this instance, the S and R stands for structural rearrangement. In this type of biopsy, we are looking specifically for something that either the female patient or the male sperm provider or partner has in their genetic makeup, and that's a structural rearrangement in their own chromosomes. Now again, this should be something you are already informed of. Not at the stage of reaching the lab would this be your first diagnosis of knowing that you had a structural rearrangement. The main identification of a structural rearrangement is in a karyotype test. If we're doing PGT-SR, we would be specifically screening your embryos to see if they carried or inherited the same structural rearrangement as either the egg or sperm provider. And then in addition, PGT-A is also performed to ensure that the right number of chromosomes are there at the same time. PGT-M then is when we're looking for monogenic conditions. This is something that's inheritable. So again, either from the egg provider or sperm provider, in your family tree, there is quite a serious condition that we would have already known about. And the premise of doing embryo biopsy and PGT is to ensure that we can avoid passing that on to offspring, or that they have a safe carrier status for their inheritance. With PGT-M, this is one of the most complex because we're looking specifically for a gene mutation causing that disease. For example, cystic fibrosis has over a dozen different mutations. So this comes down to you as an individual, as a couple, to ensure we're doing specific testing for your gene pattern to ensure that the safety of your future children can be guaranteed. With PGT-M, the list of conditions that we can test is defined by the HFEA. If you've not already heard of the HFEA, you will familiarise yourself with them because there's a lot of consent forms to follow as well. But the Human Fertilisation Embryology Authority, who license fertility in the UK, will agree to the whole list of PGT-M conditions. You can easily search this yourself. It is a very patient-friendly website, and you can look on their website for if your condition is listed. Fear not though, the clinicians and the embryology team will also do this for you, and we will ensure that we're looking for the specific test. With PGT-M, while we are looking at the embryo to ensure that a safe inheritance pattern of either a carrier or a non-affected gene has been inherited by that embryo, in addition to that, routine PGT-A will be done at the same time. So while we can ensure that the embryo has the unimpacted version of the gene, we can also ensure that the embryo has the correct number of chromosomes and has the best chance of pregnancy. Our clinic in Oxford is one of 5 clinics in the UK able to treat NHS-funded patients who need PGT-SR or M. So when it comes to doing PGT and the biopsy procedure itself, wanted to give you a little bit more detail in terms of what we do in the lab. All patients routinely now are cultured to the blastocyst stage, and that's getting you from egg collection to 5 to 6 days later. What we need when we look for embryo biopsy is to see a fully established blastocyst. When you look at a picture of a blastocyst, you can see there's 2 really important different cell populations. So you can just about make out that there is a ball of cells, and we call that the inner cell mass. that ball of cells is what becomes the baby. We definitely don't want to be touching that cell mass when it comes to biopsy. So we direct the embryo biopsy for the PGT testing to happen from that outer layer of cells. So the trophectoderm layer, or labelled as the TE layer of cells, is where we would take around 5 cells or so from, and they are what are sent for the genetic testing. The process of biopsy is done using a similar setup to the ICSI microscope, so an inverted microscope with micromanipulators to be able to hold the embryo in place, to safely use a laser to guide the needles to pull 5 cells or so off for genetic testing. As soon as we have removed the biopsied cells, the embryo is frozen, the remaining blastocyst is frozen while we wait for the results. The results can take up to a month, and then your next contact from the lab or from the doctors in that clinic will be with the results to discuss them.
Hello, my name is Tony Price and I'm the laboratory manager at TFP Wessex Fertility in Southampton. When we get the results from the genetics lab, the embryos will be classified as either normal or abnormal. A normal embryo means that it has the right number of chromosomes, and that's 46 chromosomes in total, arranged in 23 pairs. We now know a little bit more about what makes a normal embryo. And we know that in some cases, normal embryos will also contain some abnormal cells. And if that proportion of abnormal cells is low, then the embryo is quite happy and will still make a baby. If the number of abnormal cells in the embryo is high, despite the fact that there will be some normal cells available, the embryo will not make a baby.
With PGT-M results, because we are looking for a specific condition, the reports will come back and they will state, depending on the inheritance of that condition, either that the embryo has been impacted, so it is affected with the same gene mutation, that it is unaffected, or depending on the condition, potentially there could be a carrier status result as well. In addition to the status of the gene inheritance, we will then get the same PGT-A results, which will look again at if we have 23 pairs of chromosomes, or any extras, or any missing. For PGT-SR result, this type of biopsy result will again look at the number of chromosomes for the 23 pairs and if we have any extra or any missing chromosomes, but in addition we'll be looking specifically for that translocation, and it will be in more detail to ensure that the makeup and the strands of those chromosomes are in the correct order.
Once we've received your results from the genetics lab, the clinic will contact you and go through the results with you. If you have a normal embryo available, we will schedule you for a frozen embryo transfer. If we don't have any normal embryos available, then we cannot carry out an embryo transfer, and then your other options will be discussed with you. PGT-A has allowed us to learn a little bit more about what a normal embryo is. So a normal embryo can be an embryo that has 46 chromosomes arranged in 23 pairs, but it can also be an embryo that contains some abnormal cells. We call these embryos mosaic. We now know that mosaicism is part and parcel of normal embryo development, and the embryo is quite happy if up to 50% of its cells are abnormal. There doesn't seem to be a difference in the pregnancy rates or live birth rates between embryos that are uniformly normal and embryos that have some abnormal cells. If, however, the embryo contains more than 50% abnormal cells, this is classed as abnormal, as the pregnancy rates are very low. At TFP Fertility, we don't usually report mosaic findings. Instead, the report is very simple. It's either classed as normal or abnormal. The vast majority of embryos that are classified as abnormal will not implant and therefore will not make a baby.
When it comes to PGT, there is some definitive breakdowns of who and when PGT could be recommended or most useful for patients. The exception is PGT-SR and PGT-M because these are diagnostic tests looking for something in someone's inheritance pattern or family history that we want to avoid passing on to their offspring. The HFEA traffic light coding for all additional procedures does break down PGT's recommendation on the premise of what's the end goal. In terms of increasing chances of pregnancy, that's where the jury's still out a little bit in the eyes of the HFEA, and it's deemed as red. However, for reducing miscarriage, everyone is in agreement that PGT can definitely help promote this.
So making the hole in the embryo is quite safe. The embryos don't actually need their shell and will normally hatch after embryo transfer. The freezing process is also standard. So most of our patients, probably over 50%, will end up with an elective freeze in their cycles anyway. And so the freezing is very standard practice in the IVF setting. And in some cases, the results might be either equivalent or slightly better than our fresh embryo transfers. So there are some things to consider about embryo biopsy. So there are some risks that you need to be aware of. These risks are quite low. The first risk is that the embryo will not survive the biopsy in about 1% of cases. Second risk is that the biopsy may not give a genetic signal that can be read or analysed. That risk is 1%. There's also a 3 to 5% chance that a result we get doesn't actually make any sense. And finally, there is a 3% risk that the embryo won't survive thawing.
While we have procedural risks associated with biopsy, which are outlined in our patient guide, the two key factors that I implore everyone before their PGT cycle to consider is that, unfortunately, the first is that our decision to proceed with biopsy could be taken from us. What I mean with that is we have to culture embryos in the lab to reach criteria for genetic testing. So we could have everything in place to do biopsy, and unfortunately, the first risk, in my opinion, is that we might have nothing suitable. The option to biopsy could be taken from us if the embryos have not made it to the right stage. Please remember, your week in the lab is like a hurdles race. There are multiple checkpoints to get through before we can undertake genetic testing and PGT. Hopefully, we will be able to tell you on day 5 the good news that there is something suitable to biopsy, but please bear in mind, we can never guarantee this. Another consideration I implore all patients to think of before their biopsy is that, unfortunately, while genetic testing can increase chances of healthy pregnancy and reduce risk of miscarriages, that can only happen if we have a normal embryo to transfer. If the results come back and state that everything is abnormal or affected, the only silver lining in that instance is that we have avoided undertaking a transfer and putting an embryo back that would be destined to fail. Before reaching the lab, there are a few key considerations that I recommend to anyone undertaking a PGT cycle with us. The first is how many to biopsy. Now, this might seem simple. Our recommendation is always to biopsy as many as possible. However, unfortunately, there are different factors that come into play, and that's why we recommend you do have a discussion before you get to the lab about this now and give it some time to consider. When it comes to how many to biopsy, there is no minimum number. With just one embryo, we would still recommend you undertake the genetic testing to get the result. For patients undergoing PGT-A, in some instances, patients may decide that they want to still keep the option open for a transfer should they only have one embryo suitable, or if their embryos are not suitable for biopsy at the day 5 stage because potentially they're too early, then again, those patients may consider to keep the option open for transfer. If you are unsure, we recommend talking in more detail about this at your nurse planning appointment. For PGT-M and PGT-SR cycles, we never recommend an untested transfer. And that's because we know we're looking for specific conditions or genetic mutations that can impact offspring. For those instances, there is no minimum number, and if we do not reach the threshold to be able to undertake biopsy, we would not recommend a transfer without testing. On the flip side of a minimum number, again, we have no maximum number for what we would biopsy. However, unfortunately, we do appreciate that there may be a cost implication for the number to test. For that reason, we do promote again prior to starting or having your egg collection that you consider this and if you have a financial restraint to the number to be tested. For example, a patient may state to us that they can have a limit of 5 to test, and if we were to exceed the number, then we would simply freeze anything beyond that without testing. If you feel you may have a financial constraint or a specific number in mind, please do speak to the nurses at your nurse planning appointment and notify them of this. And again, ensure that you speak to the biopsy practitioners within the embryology team as you approach your egg collection. One of the other considerations for embryo biopsy is the cost. Please do check through our price list in advance And can I draw your attention to two key things? First is workup fees. If you are PGT-A, there is no workup fee because this is a blanket screening test to ensure we have the right number of chromosomes without any specific workup for you as an individual. For PGT-M and PGT-SR, there are workup fees involved with these types of PGT. This is reflective of the extra procedures and planning that go into ensuring that the test reflects your specific mutations or inheritance patterns that we need to be diagnosing. When it comes to the biopsy fee itself, this is per embryo, and again, you may see on our price list that it is a fixed rate for the first embryo, and then a standard fee thereafter for any embryo extra. When you get to your nurse planning appointment, the nurses will go through your treatment plan. In the majority of PGT cycles, we recommend a standard freeze-all embryo approach, meaning you will have no medication following your egg collection because the plan is to do embryo freezing with genetic testing first. After watching this video, your next step in the process will be your nurse planning appointment, where you can ask any more questions or specify your treatment plan. In our patient information guides, specific to the type of PGT that has been recommended to you, is extra information and references such as graphs and expected abnormality rates according to age, links to the HFEA, and any extra guidance that you may find useful prior to your nurse planning appointment. At your nurse planning appointment, you will be able to ask any questions that you may feel are still left unanswered following this video and after reading our patient information guides. I do suggest that when you get to nurse planning, you agree the plan with the nurse in terms of your definite biopsy plan and if you have a minimum and maximum number to biopsy. Prior to your egg collection, and ideally before nurse planning, we would ask that you complete your PGT patient consent form. On this consent form, all three types of PGT are listed. Please tick the type of PGT relevant to you and your circumstances: PGT-A, PGT-SR, or PGT-M. If when completing your PGT consent, you have any unanswered questions, then please do contact us. We hope you found this video useful in understanding everything PGT. We look forward to welcoming you into the lab once you have your egg collection. And if you have any unanswered questions, your nurses should hopefully be able to pick those up with you at your nurse planning appointment. But otherwise, always feel free to ask to speak to an embryologist.